Good morning, colleagues. Today I'd like to discuss a powerful bedside tool in our clinical arsenal, using point-of-care ultrasound to evaluate fluid status through assessment of the inferior vena cava, or IVC. This non-invasive technique has revolutionized our approach to fluid management, especially in critically ill patients. Why use the IVC for fluid status assessment? The traditional methods for assessing fluid status, physical examination, central venous pressure monitoring, and pulmonary artery catheterization all have significant limitations. Physical examination findings like jugular venous distension, peripheral edema, and lung sounds have poor sensitivity and specificity. More invasive methods carry procedural risks and complications. Enter IVC ultrasonography. This technique offers several advantages. It's completely non-invasive. It provides real-time information. It's rapidly performed at the bedside. It allows for serial assessments without harm to the patient. It correlates well with central venous pressure and right atrial pressure. The IVC acts as a dynamic conduit between the systemic venous system and the right atrium. Its diameter and collapsibility reflect right atrial pressure, which in turn reflects a patient's volume status. This makes it an ideal window into a patient's fluid state. Locating the IVC under ultrasound. To begin, position your patient supine. Use a low-frequency 2.5 MHz curvilinear or phased array transducer, as these provide adequate penetration for abdominal imaging. There are two primary approaches. Subcostal view. Place the probe in the subxiphoid region with the marker pointing toward the patient's right side. Obtain a subcostal 4-chamber cardiac view, then rotate the probe clockwise until the IVC is visualized entering the right atrium. Longitudinal view. Place the probe in the midline of the abdomen, just below the xiphoid process, with the marker pointing toward the patient's head. Slide slightly to the patient's right of midline to visualize the IVC in long axis, differentiating IVC from aorta. This is a crucial skill, as mistaking one vessel for the other will lead to erroneous assessments. Here are the key differences. Location. The IVC lies more anteriorly and to the patient's right. The aorta is posterior and slightly to the left. Diaphragmatic foramen position. The IVC passes through the most anterior shallow foramen of the diaphragm in the supine position, while the aorta passes through the deepest posterior foramen. The esophageal hiatus is positioned between these two. This anatomical relationship can be a reliable landmark for correctly identifying these vessels. Wall thickness. The IVC has a thinner, more collapsible wall than the aorta. Branching patterns. The IVC receives the hepatic veins, which you'll see entering anteriorly. The aorta gives off the celiac trunk, superior mesenteric artery, and renal arteries. Pulsatility. The IVC shows respiratory variation, while the aorta demonstrates arterial pulsations. Compressibility. The IVC is easily compressible with probe pressure. The aorta is not. If you're still uncertain, apply color Doppler. The IVC will show blue flow away from the probe as blood returns to the heart, while the aorta often shows red flow toward the probe as blood flows away from the heart. Optimal location for IVC measurement. The standard location for IVC measurement is approximately 2 to 3 cm distal to the junction of the IVC and right atrium, just caudal to the hepatic vein confluence. This location provides the most consistent and reproducible measurements. Measurements should be taken in both inspiration and expiration, as the IVC diameter varies with respiratory cycles due to changes in intrathoracic pressure. Some experts recommend averaging 3 measurements for greater accuracy: IVC diameter and right atrial pressure. The absolute diameter of the IVC correlates with right atrial pressure as follows. IVC diameter of less than 2.1 centimeter that collapses more than 50% with sniffs suggests normal RA pressure, 0 to 5 millimeter of mercury. IVC diameter of more than 2.1 centimeter that collapses less than 50% suggests high RA pressure, more than 15 millimeter of mercury. Values between these extremes suggest intermediate RA pressure, 5 to 15 mmHg. Remember, these values apply to spontaneously breathing patients. The interpretation changes significantly in mechanically ventilated patients. The Cava index and its measurement. The Cava index, or collapsibility index, is the percentage change in IVC diameter during respiration. It's calculated as Cava index is equal to maximum IVC diameter minus minimum IVC diameter divided by maximum IVC diameter and multiplied by 100%. In spontaneously breathing patients, the IVC typically decreases in diameter during inspiration due to the negative intrathoracic pressure. A Caval index more than 50% suggests fluid responsiveness, while a Caval index of less than 50% suggests the patient may not respond to additional fluid. Collapsibility and how to measure collapsibility refers to the degree to which the IVC decreases in size during inspiration in spontaneously breathing patients. To measure, obtain a long-axis view of the IVC. Freeze the image during quiet breathing at maximum and minimum diameters. Measure the diameter at both points. Calculate the percentage decrease during inspiration. An IVC that collapses completely during normal inspiration suggests hypovolemia, while minimal collapse of less than 50% suggests euvolemia or hypovolemia. Distensibility and how to measure. In mechanically ventilated patients, the relationship reverses. Positive pressure ventilation causes the IVC to increase in size during inspiration. Here, we measure distensibility. Distensibility index is equal to maximum IVC diameter minus minimum IVC diameter divided by minimum IVC diameter and multiply by 100%. A distensibility index of more than 18% predicts fluid responsiveness with good sensitivity and specificity in mechanically ventilated patients. Limitations of IVC assessment. Despite its utility, IVC ultrasonography has important limitations. Technical challenges. Bowel gas, obesity, and wound dressings can limit visualization. Patient-related factors. The technique is less reliable in patients with increased intra-abdominal pressure, right heart failure, tricuspid regurgitation, or pulmonary hypertension. Ventilation mode. Interpretation differs between spontaneous breathing and mechanical ventilation. Operator dependence. Like all ultrasound techniques, there's significant inter-observer variability. Static versus dynamic measurements. Single measurements are less valuable than trends over time. Pitfalls in IVC measurement. Several factors can lead to misinterpretation of IVC findings. Probe pressure. Excessive transducer pressure can compress the IVC, falsely suggesting hypovolemia. Breathing variability. Deep inspirations can cause exaggerated collapse compared to normal tidal breathing. Measurement location. Measurements too close to the right atrium or hepatic veins will be less accurate. Right heart conditions. Tricuspid regurgitation, pulmonary hypertension, or right ventricular dysfunction can dilate the IVC regardless of volume status. Mechanical ventilation settings. High PEEP levels can dilate the IVC, mimicking volume overload. Cardiac tamponade. This can paradoxically cause IVC dilation despite hypovolemia. Conclusion. Ultrasound assessment of the IVC provides valuable information about a patient's fluid status and potential responsiveness to fluid administration. When properly performed and interpreted within clinical context, it can guide fluid management decisions and improve patient outcomes. However, remember that no single parameter should dictate clinical management. IVC measurements should be integrated with other clinical and laboratory data, and serial assessments are more valuable than isolated findings. I am Dr. Chen Chiaqing. See you next time.